And what we're going now to do is we normally have at least one postdoc person talking to you about the research. And we're delighted now to be introducing Laura Hutchinson. Laura completed her PhD this year. And Laura is working as a community pharmacist. And she's the mother of 2.5 little ones. And you know what the half means. And Laura is working extremely hard now because of COVID. Laura has pre-recorded her presentation, and just by way of introduction, to say to you that Laura Laura, as I said to you, is a community pharmacist. I'm just trying to find her information. Can't find her information, but I know Laura, and Laura is currently working as a community pharmacist and has completed her PhD with us, and undertook her pharmacy, undergraduate pharmacy in Ulster. And so over to you, Laura.
Hi everyone, so today I'm going to discuss my PhD, which was looking at the transfer of antiepileptic medication in breast milk and the decision-making processes of women with epilepsy regarding infant feeding. So I'll just give you a quick background first of all to the study, and I'll talk you through like slide by slide to make it easier for you to follow. So slide 3 then. So human decision making is a complex behaviour, and it involves many factors. So for women with epilepsy who become pregnant, it's complicated further because they can't stop taking their medication, but they still need to consider the health of their unborn baby along with themselves. So breast milk is widely recognised as the best nutrition source for babies, as we all know, with the World Health Organization recommending exclusive breastfeeding for 6 months and beyond. Epilepsy is the most serious neurological condition worldwide, and it affects over 500,000 people in the UK. In Northern Ireland, there's around 150 women each year who have epilepsy and have a baby. So these women can't stop taking their medications, and although the likes of the Epilepsy Society and NICE do recommend that they breastfeed, the decision is more complex than for a woman who isn't taking chronic medication. So medication transfer in breast milk is already recognised as a blind spot in healthcare. So many women with chronic conditions choose to formula feed because there is limited information in the area, and what is there is often conflicting and lacks clarity, meaning that it's a difficult decision for both the women and for their healthcare professionals. So to conclude then, there is limited information on the decision making of women with epilepsy regarding infant feeding, and limited information on the transfer of anti-epileptic drugs in breast milk. So salivary therapeutic drug monitoring is a established method. It's been used successfully in both adults and children who are taking medications, but the information on infants who are breastfed, so their mother is the one that's taking the medication, is very limited. But having information in this area might help then make the women's decision making less difficult. So slide 4 then. So the aim of the study was to determine the feasibility of using salivary therapeutic drug monitoring in infants who were exposed to anti-epileptic drugs through breast milk, and to explore what factors had the biggest influence on women with epilepsy regarding their infant feeding choice. So there was a literature review conducted first, and then phase 2 consisted of both qualitative and quantitative data collection. So this was done through 3 objectives. So first of all, we wanted to conduct the systematic review to see if salivary therapeutic drug monitoring in infants was actually going to be feasible. Then to conduct a feasibility study to determine how much of the anti-epileptic drug was transferring to the infants, and that was through both breast milk and saliva. And then also to explore how women with epilepsy make decisions about infant feeding. So phase 1 then of the study, we're looking at slide 7 now, was a systematic review, and this was published in the British Journal of Clinical Pharmacology. Now we looked at all medications that had been successfully monitored using saliva in infants and neonates, and we determined that salivary therapeutic drug monitoring has good potential, especially if the compounds are neutral or weakly acidic. pKa was the most influential property then determining their transfer into saliva. So following this then, we'll look at the phase 2 then, and we had to get ethical approval and governance then, and we got governance with the Belfast, Western and Northern Health and Social Care Trusts, and we were able to recruit 19 women then for the study. So they had to have active epilepsy and be taking one of the most commonly prescribed AEDs to manage their condition. They must have been able to understand English, and we recruited them whether they were planning to breastfeed, formula feed, or combi feed. So in phase 2 then, I'm going to talk about the quantitative part first. So this was the feasibility study to determine if using saliva therapeutic drug monitoring in an infant was feasible. So though we recruited 19 women originally for the study, not all of them followed through to the end. And I suppose with it being such a busy point in their lives, it wasn't surprising that we had a bit of a dropout. But we were able to collect saliva from 13 infants and breast milk then from 5 mothers. So out of our study who followed through to the end, we had 5 out of the 13 who breastfed, which is slightly lower than the general population of women who leave hospital breastfeeding. This is usually around 48%, and in our study it was about 38%. So we collected the samples then at 1 week postpartum, and then again at 3 weeks postpartum. So the samples, if you go to slide 11 now, the samples then were collected as shown in the picture. So it was using an infant swab, and that was placed inside the inside of the baby's cheek until saturation occurred. The samples were then transferred to Eppendorf tubes and were stored then at -80 degrees in the HTA freezers. So if we look at slide 12 then, this shows the most popular medications that the women were prescribed. So this was in sort of what we had is in what is in the general population of women who are pregnant. So the 4 most commonly prescribed drugs that we've seen were lamotrigine, carbamazepine, levetiracetam, and sodium valproate, and then combinations of these as well. So I'm not going to talk an awful lot about the method development, although there was a massive background into this. But the two drugs which we were successfully able to get method development for then was lamotrigine and carbamazepine, because these were the 2 most commonly prescribed in the breastfeeding women. And we were successfully able to develop methods of analysis for these 2 compounds, and this shows their limits of detection and quantification here in the tables. So unfortunately we were only able to analyse participant 1's breast milk, and she was taking lamotrigine monotherapy. So samples 1 to 4 then show her first set of samples, which were collected at around 1 week postpartum, and then the second set of samples then 5 to 8 then showed the second set of samples, which would have been collected at about 3 weeks postpartum then. And we were able to determine that she had about 0.32 micrograms per mil of lamotrigine in her breast milk. And we would hope then the next thing that we would be doing would be analysing the baby's saliva then to compare it then to see how it directly compares to the amount of lamotrigine in her breast milk. So as I said, because of time restraints and because of COVID as well shutting down labs, we were at the final stages of testing and it was all cut short. So unfortunately, if you see on slide 15, this shows the samples that are still to be analysed. So the samples that are highlighted, these are the ones that we have breast milk for, and they would be the ones that we would be testing next. So the other the samples that we got some saliva samples on their own, and the reason that we did this is so that we can directly we can consider placental transfer. So you would be looking at these women and thinking at their first set of samples that there might be some saliva or might be some of their medication in the baby's saliva, whereby the second set of samples at around 3 weeks, any placenta transfer should have disappeared, so there shouldn't be anything in them samples. So we'd hope that these samples will be completed like as soon as possible when some sort of normality returns. So we go on then to slide 16. So I'm going to now talk about the qualitative part of the study. So this was a focused ethnographic study, and it was analysed using theoretical thematic analysis. So it was focused ethnography as we looked at the course of the women's pregnancy to see if their decision making changed over the course of their pregnancy and that particular time point in their lives. So there were longitudinal interviews which we conducted with the women, and they were conducted at around 20 weeks, and nearly 30 weeks and 3 weeks then postpartum. So we first of all looked at their demographics, we looked at their epilepsy background, and then we had some open and closed questions then regarding their infant feeding. So some of the demographics of the study then, which I'm going to show you here on slide 18, are are really just to set the scene in terms of getting to know the women then before we discuss the open-ended questions. So the women in our study who chose to breastfeed were all over 30, and they were in employment and they were well educated. They were all in established relationships, were socio-economically more stable and living in more affluent areas in Northern Ireland. And this is in accordance with results from the general population, looking at those women who are more likely to breastfeed. So if we look now at slide 19, this diagram shows how we use the theory of planned behaviour and how it is useful in predicting the initiation of breastfeeding. So if we consider that even if the women had a good attitude to breastfeeding, if they had positive influences like peer support and things, and they wanted to breastfeed, if they didn't believe in themselves, if their perceived behaviour control or their self-efficacy, if that wasn't there, then they had a low chance of being able to breastfeed anyway. So this sort of shows that it is the most important consideration in their decision to breastfeed. And even if attitude and subjective norms are involved, having a low perceived behaviour control overruled their decision to breastfeed. So using thematic analysis then, 4 themes evolved from the study, and these can be seen here. They were definitely going to breastfeed, definitely not going to breastfeed, wanted to try breastfeeding, and listening to the advice of others. So using then, on slide 21, using the objectives and their attitude and their subjective norms, then we were able to break these down into sub-themes. And I mean, the majority of the subjective norms were similar to what has been seen in the general population. For example, that I want to breastfeed because it's better for my baby, or it's more convenient for me, or it's less convenient for me, for example. So I'm going to mainly focus just on the ones that were specific to women with epilepsy. So if we look now at slide 22, this group of women were definitely going to breastfeed, and they all had positive attitudes towards it. So the benefits for their babies weighed heavier on them than the risk of like medication transfer or other subjective norms. They intended to breastfeed even if not all of them were able to, or some of them ended up, for example, combi feeding. And some had concerns about the increased seizure risk that they thought the breastfeeding would subject them to, because breastfeeding was deemed to be more demanding. And the self-efficacy in these women, as I said before, was a contributing factor for failure. So slide 23 then. So this group of women were definitely not going to breastfeed, and they had mixed attitudes towards it. So for example, one woman said, I don't like breastfeeding. Another said, oh, I fully agree with it. I have nothing against it at all, just definitely not for myself. So they were definitely not going to breastfeed, and they placed higher value on convenience for themselves, so the likes of getting into a routine, than they did on the benefits to their baby by breastfeeding. And medication transfer was rarely mentioned by this group of women. So slide 24 then. So this group of women wanted to try breastfeeding, but they mostly all had positive attitudes towards breastfeeding, and they often were able to name many benefits. However, they thought it was expected of them more so than they wanted to do it. So for example, one woman said it's the better option for the baby, so I suppose it's the best thing to do, really. Many factors influence these women, and arguably they are probably the most important group of women in the study, because they had strong and concrete reasons why they weren't going to breastfeed. The 2 of the most sort of applicable to the study were the medication transfer, so they were worried about that. So for example, one woman said, well, it's mainly because of the lack of information about the medications going into breast milk, mostly the clobazam. So they were concerned about medication transfer. And seizure risk then, and how demanding breastfeeding was deemed to be. So one woman said, I mean, I can always just imagine breastfeeding a baby and having a seizure in the middle of it and collapsing on top of him or something. So this group of women, they had positive attitudes, they were able to name loads of benefits, but the subjective norms affected their decisions in a negative way. And the 2 biggest ones then were the medication transfer and how demanding breastfeeding was, which could bring on a seizure for them. And some of the women actually regretted then at the end of the study not having tried breastfeeding. So we'll move on then to slide 25 then. So this was listening to the advice of others. So this sort of theme reflects the primacy of the influence of others or subjective norms in women's decision making. So subjective norms are determined by their perceived social pressure from others, and for an individual to behave in a certain manner, and their motivation to comply with other people as well. So it was clear from the study that family and friends weighed heavier than healthcare professionals on the women's decision making. So if you look at, we had 4 family and friends and 4 partners, so that brought it up to 8, whereas only 2 women mentioned their healthcare professionals as being an influence. So, I mean, it happened either way. We had negative influences and positive influences. For example, partners who didn't want the women to breastfeed, partners who did want women to breastfeed. Looking at their healthcare professionals, most of the women did trust the healthcare professionals' advice, and they didn't even look for any further information then after they were given it. So if we look at slide 26 then, just some other points then to consider from the study were that only 6 women looked up information on infant feeding, with the internet, social media and midwives being their main source. So if you consider how many people were worried about the medication transfer but they didn't go looking for more information, that was very little, as very few women did it. Also, support from the healthcare professionals was very inconsistent, especially about breastfeeding and epilepsy, with some conflicting information being given. And the worries and concerns of women with epilepsy about infant feeding are in the most cases the same as the general population, except for their fear of increased seizure risk and medication transfer. And their influences rarely changed over the course of their pregnancy. Most had made up their minds by their booking appointment. By the first interviews, they'd all really decided, apart from one woman who, if they were going to breastfeed or formula feed. Although there was a lot of new barriers that arose once the babies then were born. So if we look at now slide 27, so the strengths of the study and the contribution to knowledge then, the literature review determined that salivary therapeutic drug in infants was a feasible method, and it allowed us then to develop the rest of the study and let the study go ahead then, because we knew that it was feasible. We had an unbiased sample of women, so we had women from a lot of different backgrounds, from different beliefs and experiences, which meant that the data was really rich and powerful. It was the only study so far that has looked at the theory plan behaviour to identify factors that influence women's decision making in regard to infant feeding and epilepsy. And we also were able to show that salivary sampling and the breast milk sampling was an accepted method. None of the women had any issues about it. Babies rarely were phased at all unless they were due a feed and they were wondering why the swab was being placed in their mouth. And finally then, so in the future we would love to see, if once we have all the samples analysed, if we could go back to the women and see if they had the information from the samples, would that have changed their decision making at all? It'd be great to have an epilepsy feeding, the development of a decision aid for the women with epilepsy. And it would be good as well to consider breastfeeding duration and if that was affected by their epilepsy, because other studies have shown that women taking chronic medications, it can often affect the duration of breastfeeding. We would love to take it UK wide as well and do a discrete choice experiment to see how women with epilepsy across the UK, how their influences are determine their infant feeding choices. And we feel that there's a big need for education for both for healthcare professionals as well in the area of epilepsy and breastfeeding. And that's us.
Well, thank you very much, Laura. And Laura's here in person with us, and Laura would take some questions if there are any. I don't see any in my text box at the minute, but Laura has said that she'd be happy to respond to any questions that have been that people have. Laura, do you want to say anything?
Well, just thanks for letting me speak. I didn't trust my connection here out in the remote countryside, so I just had pre-recorded it, but it was great to join in and watch everybody else this morning so far as well.
Mm-hmm. Is there any message you'd like to send about your research?
I suppose that it is such a understudied area, and just hearing the women's views and getting the differences between them and the general population was really important for this group of women. And the fact that, medication transfer and the seizure risk isn't something we had really thought about before. So the fact that they deemed breastfeeding so much more demanding than formula feeding, and they were scared then that would bring on seizures, that wasn't something we had thought about really before the study. So it was brilliant to get all that information from them.
I have a question for you. Does lamotrigine in saliva have an effect on the baby?
Well, at the moment we haven't gone down that route yet of seeing what effect it has on the baby. We haven't tested all the saliva yet, but it is something that we're hoping to do in the near future once things go back to normality in labs and that. So unfortunately, it was just cut a bit short because of COVID and with time restraints as well. So we haven't tested the saliva yet, but that wasn't really our part of our study either, was to determine the clinical effect. That would be further down the line. Ours was more just to see if we could actually detect the levels in the saliva.
That's postdoctoral research for you, Laura. You needn't think because number 3 is on the way that you're going to be escaping. Research that lasts forever. It's like speaking to Maria earlier on, you get hooked on this. So I hope that you will continue on. Folks, I'll have to leave it for there. And thank you very much, Laura.
Thanks.
Rachel has also said if there are any questions for her, she'll answer them as well. Colleagues, I'm sorry that we didn't have a break, but I'm 10-minute break as from now, and then we'll have Professor Sue Down, who will be sharing her paper with us. So have a break for 10 minutes and see you all back in 10 minutes. Thank you very, very much for all your attention so far. Thank you to all our speakers so far. Thank you. Bye. See you in 10.